Good morning to one and all. I am a third year resident from Grand Medical College. My topic for today is a better choice in conservative management of middle third clavicular fractures in an Indian population, the broad arm sling versus the figure of 8 bandage. This is an AP radiograph of a 27-year-old male with overlying skin normal, no distal neurovascular deficit. Most of us would agree, considering it is a relatively undisplaced fracture, we would go for a conservative management. But the question lies in the fact that whether we would go for a figure of 8 bandage or a broad arm sling. Clavicle fractures account for 4% of all the fractures and 44% injuries of all injuries to the shoulder girdle. Middle third clavicular fractures are most common in incidence, and it has a bimodal age of distribution. Middle third clavicular fractures occur in that area because it is the least medulous area, not having any ligamentous or muscular supports. And as you can see in the diagram, the medial fragment is pulled upwards by the pull of the sternocleidoid muscle, and the lateral fragment is pulled inferior-medially by the weight of the arm and the pectoralis major muscle. So figure of 8 bandage and broad arm sling are indicated in undisplaced and partially displaced fractures with cortical contact, and majority of the clavicle midshaft fractures till date are treated by this modality. Figure of 8 bandage is applied, it has to be applied with proper tightening. The back is kept in an arched position, and after that it is applied. So basically it presses on the medial fragment downwards to achieve alignment. A few rare complications associated with this are discomfort, pain. Discomfort and pain is quite a common association, but a few rare complications associated with it are restriction of venous blood return and rarely nerve compressions. The broad arm sling eliminates the force of the gravity which is pulling the lateral fragment downwards and helps to achieve alignment. Elbow stiffness is one of the disadvantages associated with a broad arm sling. Operative management is included in open fractures, fractures with skin tenting, in floating shoulder cases, and in prolonged non-union cases. So in our study, we recruited 296 patients over 3 years. Figure of 8 bandage group had 152 patients, and the broad arm sling group had 144 patients. We excluded all clavicle fractures which would definitely require an operative management, such as open fractures, fractures with a neurovascular deficit, and we included all patients in between the age of 18 and 60 and acute middle third clavicular fractures of less than 10 days. So we evaluated radiographically based on time to union, malunion, non-union, and clavicle shortening. In our results, we found better results for the broad arm sling group with respect to time to union, malunion, non-union, as well as clavicle shortening, but only the malunion group showed statistical significance. For clinical and functional evaluation, we used the pain visual analog score, which was evaluated at week 1, week 4, 8, 24 weeks, 1 year, and 2 years. And the functional evaluation was done by dash scoring, constant score, and Nottingham clavicle score. On the pain visual analog score for week 1 and week 4, we got a better outcome in the broad arm sling, which showed statistical significance. Thereafter, there was no statistical significance between the two groups. Similar results were found for the dash score, where week 1 and week 4, we had a statistical significance in favor of the broad arm sling. Thereafter, it was equal. Comparing the other two functional outcomes of the constant score and the Nottingham score, we found excellent results with both groups, and there was no statistical significance in both the groups. On a thorough review of literature to the best of our effort, we did not find any Indian study comparing these two conservative modalities of management. Although a paper by Ersen also shows similar results as we found, where they have said that the broad arm sling is easier in application as compared to the figure of 8 bandage, and it is more compliant for the patient and reduces pain earlier. A similar paper by Anderson gives us the same result, where they have advocated that the figure of 8 bandage causes more discomfort as compared to the broad arm sling. A systematic review taken from an Indonesian journal was done over 12 papers which was done, and they found similar results where the functional outcome, the union-related complications were lesser with the broad arm sling group. I would like to conclude my presentation by saying that both conservative managements, yes, they both have a good outcome, but the broad arm sling definitely proves to be better in terms of pain relief, comfort, compliance, a faster functional recovery, and fewer union-related complications. I personally would advocate the use of a broad arm sling over a figure of 8 bandage for treatment of my patients with middle third clavicular shaft fractures. Thank you.